Hello, Dr. Deepa. It's wonderful to have you. Welcome to the Low Carb Conference.
Hi, Pashini. Thank you for having me.
I'd like to take a quick minute and introduce you to our audience. For those of you who do not know, Dr. Deepa Mahananda is from Sydney, Australia. She graduated from Western Sydney University in 2012 and completed her junior medical officer training in 2012. Her postgraduate qualification include the fellowship of the college for general practitioners. She's specialized in sexual health, family planning certificate. She's also done a diploma in child health from the University of Sydney. She's extremely passionate about teaching and is also a conjoint lecturer with Western Sydney University. She currently works full-time at Sydney Low Carb Specialists. During her early clinical experience, she started seeing more patients with metabolic health conditions. She's going to talk about how she got interested into low carb and what she does. She's also, certified ketogenic nutritionist, credentiated by the American Nutrition Association. She is also a member of Low Carb Down Under. She's extremely passionate. For those of you who have followed her on social media, you know how actively she is promoting and following low carb, and her special interest lies in women's health. And today, that's our discussion going to be on gestational diabetes. Dr. Deepa, why don't you tell us about your journey into low carb?
Thank you for the introduction, and it's really lovely to be here supporting the first Metabolic Health Conference for India. It's a wonderful initiative that you've put together, so congratulations to the whole team. So just to speak a little bit about my journey towards low carbohydrate medicine, I graduated in 2012 from medical school, so it's quite some time now. I've been a practitioner for 11 years. And when I graduated, my passion was always to go into general practice, which is also known as family physician. And the reason for that is because I'm so passionate about preventative medicine and trying to keep people out of hospital, but also not just to keep them from sickness, but to help them to thrive. And I thought general practice was where my calling was. And when I ended up there as a registrar, a trainee, and I was starting to learn from my mentors and my colleagues, I started to realize that much of what I'd been taught in the traditional framework of how we deal with chronic disease is much like a band-aid, and it was never really reaching the root cause of illness. So unfortunately, I'd see patients who I'd give a prescription to, I'd ask them in a very cursory way about diet and lifestyle, but I wouldn't have very much effective interventions to offer to them. And then unfortunately, I would see them deteriorate or perhaps get worse over time. And it was sort of about around that time as well that I had my own personal health issues. I was diagnosed at the end of my medical school with stage 4 endometriosis, and I began to explore what are some other avenues to be able to manage my condition in conjunction with the traditional medical framework. And so thus I happened upon low carbohydrate medicine and started to learn a lot from my colleagues here in the Low Carb Down Under organization, and attended a conference which transformed my whole outlook upon how we treat chronic disease and how we optimize health. And that was in around 2017 when I attended that conference. So from that point, it's just been a lot of research and learning from my patients who've chosen to use this methodology, and learning from my current practice as well, and applying the information that we have. And as people may have already spoken about, low carb is actually not a new concept. It's been around for more than 100 years, and it's actually underpinned by our ancestral way of eating. So you could even say it's been around for millennia. So it's really about us reintroducing and educating around the concepts of how we have been, how we've evolved as humans, and what kind of nutrition looks like for to optimize our own health. And to that end, we created our own clinic to be able to provide this in a very comprehensive way. So my husband, Dr. Alex Petruszewski, who's talking later in the conference, and myself are directors of Sydney Low Carb Specialists in Sydney. And we have a dietitian, a health coach, and an exercise physiologist within our integrated team. And we work quite holistically with our patients in applying nutritional medicine that's within a low carbohydrate framework, and also putting that across, like using that across the board for a wide variety of different conditions, and also to optimize health as well.
That's amazing. So you get to practice in the way you would like. We'll dive right into the topic, Dr. Deepa. Maybe tell the audience, what is the difference between regular diabetes type 2 versus gestational diabetes?
So it's just the distinction with the time at which it's diagnosed. So gestational diabetes is diabetes that comes to light during a pregnancy. So it's a abnormal blood sugar that is first recognized in pregnancy, whereas the type 2 diabetes is abnormal blood sugar that's diagnosed anytime outside of the pregnancy itself. However, a significant number of those who are diagnosed with gestational diabetes are actually pre-diabetic prior to their pregnancy, and they're quite unaware of this, because having an abnormal blood sugar in many ways can be quite a silent disease, and it can take up to 10 to 15 years to actually be diagnosed with type 2 diabetes. So that's the main difference between the two.
So how would a person, preventively maybe diagnose pre-diabetes before they, let's say, plan for a pregnancy?
Yeah, so one of the key things I often advise is that we should be aware of what our blood sugar is, and be testing, particularly when someone is interested in preconception at that early stage, understanding what their fasting blood sugar is, what their HbA1c is, their C-peptide as well, which is a marker of pancreatic function, and importantly, what their fasting insulin level is. So these 4 biomarkers are incredibly important to the early diagnosis of pre-diabetes, and thus we can try and prevent this person and manage their blood sugar more effectively, so that we don't unveil what will then may turn out to be a gestational diabetes through a pregnancy. And by doing that, we can prevent some very serious knock-on effects for both the baby and the mother. Because what happens in the situation of a pregnancy with gestational diabetes is that there is an increased risk of preeclampsia and high blood pressure for the mother, and also an increased risk of cesarean delivery because of having large for gestational age babies, meaning that babies can actually be on the larger side. They call this macrosomia. So that's an increased risk for women who do develop this condition through the pregnancy. The other main risks as well are around, unfortunately, are around stillbirth and miscarriage. And this can occur as well in at higher rates in pregnancies that have uncontrolled gestational diabetes, particularly. So where this one of the take-home messages I want people to take away from this is that having the condition in itself is not reason to panic, because it does not mean that all of a sudden all of your risks are so high. The risks actually go this high when the blood sugar is uncontrolled, and that is the key. So really recognizing this prior to the pregnancy means you've got a lot of time to be able to engage in some very proactive lifestyle measures. And then when you enter the pregnancy, particularly in that first 4 weeks, one of the issues is that we know that if we don't control the blood sugar very well, we can have a higher rate of neural tube defects. So this is the formation of the spine in the baby. And when we enter a pregnancy, if the blood sugar is well controlled, we can actually reduce the rate of this. And this is quite a powerful tool that we have to reduce this serious risk. So there's a lot that can be prevented in the preconception phase. And you might have heard of the phrase, the genes load the gun, but the environment pulls the trigger. And preconception is a hugely important phase in a woman's life, as well as her partner as well, because the health of both of those two individuals matters to the health of the sperm and the egg, which meet to form the embryo. And if we can provide the best metabolic health to both those individuals who are involved in the conception, then we know that the embryo will be the healthiest that it can possibly be and have lower risks of experiencing problems through their lifetime, and also then future generations too, because at the moment what we're dealing with is an intergenerational issue with diabetes. So many generations being affected by diabetes because of the exposures from the time they were in utero.
That is really fascinating because, you're not just looking at preventing and making your life better, but it is also, as you mentioned, generational that would require. So just building on to this, as you already said, it's nothing to panic about, but it needs to be managed and controlled. What are the measures and how can low carb really fit into that, especially for the gestational diabetes?
So the traditional management in Australia, at least, is that we often talk about diet change. And particularly at the moment, the guideline is an extension of our standard dietary guidelines. So they speak of using a low glycemic index diet with portioning control, but perhaps having snacks in between every meal to ensure that the overall caloric intake for a pregnant woman is still adequate enough for the pregnancy. But the recommendation, unfortunately, sits at the moment at a minimum of 175 grams of carbohydrate per day. And this was arbitrarily really put together based largely on studies that involved men. So using their dietary intake requirements and sort of adding on what we assume would be the amount needed in pregnancy and for the developing baby. And then we also advise about exercise because that is a powerful tool as well to manage blood sugar levels and increase insulin sensitivity. Then the next two factors that occur often is that when diet therapy tends to fail, because I feel that when we give women such a high carbohydrate minimum to achieve, they can often exceed that. And oftentimes they will find that it is difficult to actually proceed through their pregnancy eating that way. They can feel quite hungry as well because it's really low in protein and fat. When they're eating so many carbohydrates, it is almost equivalent to 9 servings of grains per day. So that then leads into potential need and use of medications such as metformin and insulin if we still cannot control the blood sugars adequately. So in a low carb framework, what we tend to then look at is out of the 3 macronutrients, which are carbohydrates, protein, and fat, the one and only macronutrient that significantly increases your blood sugar is carbohydrates. And the research is showing that even if you have a mild elevation in your blood sugar during a pregnancy, then that can dramatically affect the baby and the pregnancy itself. So what we do is to try and reduce the insulin resistance that occurs through pregnancy, and it is natural and normal for an insulin resistance to occur. So I'll just explain why that is. In the first half of the pregnancy, the woman is in an anabolic phase, meaning that she's starting to build fat stores within her body in the preparation for the second half of pregnancy, where she'll partition that fat across to the fetus or the baby, the growing baby. And that baby will then rapidly gain weight at that stage of the pregnancy. That's usually happening in the second half of the pregnancy. So the second half is where we actually have the highest insulin resistance in the woman in an effort to get this fat moving from the woman to the baby. And that's how the normal pregnancy and normal physiology of pregnancy is meant to progress. So in the whole scheme of that, the pancreas of the woman needs to actually increase its insulin production. So that actually goes up by 2 to 3 times normally during pregnancy. And when that occurs, if you're having quite a high carbohydrate load, so for instance, if you're trying to achieve that minimum 175 grams, you're at least having 45 grams of carbohydrate with every meal at a minimum in this framework. And that is quite, it still can be quite high and provoke quite a high blood sugar if that methodology is used. And I think that's where it goes wrong for many women, and they find that they fail diet therapy and they feel then they need to go, well, their doctor's advice at that stage is usually to go on to medication. And actually, as Lily Nichols, who's a very experienced and knowledgeable dietitian in this area in America, she says that actually, you know, they didn't fail diet therapy, but the diet failed them. And it was the diet that was the issue in the first place. So in a low carb approach, we would be looking at something that is around 90 grams of carbohydrates, if not needing less in some instances, depending on if the woman had metabolic syndrome prior to entering pregnancy, or if they had prediabetes prior to pregnancy, then we may need to go lower. And this is done in a very individualized, very supervised manner. Otherwise, it's usually on average around 90 grams of carbohydrate would be per day would be a target. And even in some women, they can tolerate higher than that without any blood sugar excursions. And the emphasis then gets placed upon increasing quality proteins and healthier fats in the food, such that we can increase the nutrient density as well. Because often carbohydrates that are grain derived are quite low in nutrients unless they are fortified. So at least in Australia at the moment, we fortify the wheat flour with synthetic folate and iodine and even iron in some instances to certain foods in an effort to prevent deficiencies across the population who may be considering pregnancy. So these are some strategies that have been used, but if you kind of think of it a bit differently, actually, we could be focusing on health promotion around the most nutrient-dense foods to assist in a low carb framework for pregnancy. So we can do a very well supported and supervised way of proceeding with the pregnancy that can avoid gestational diabetes or even manage gestational diabetes better.
That was really insightful because you mentioned the priority in what the macronutrients are. Just diving a bit into that, are there any standard? I know you mentioned there's, you know, it's very individualized, but are there standards for the quantity of carbohydrates that one needs to take during pregnancy?
There isn't actually any standard guideline, and you'll be surprised when you dive into the literature on this that because pregnancy has always been a difficult area of science to investigate in a randomized controlled trial way. So we're never going to have some of these rigorous trials that people will call for in this area. It would be purely unethical to be doing that. So much of the science we have is actually from observation or from animal studies. And also, as I was saying, much of the research, if you looked at, actually there was a recently published study that screened for the dietary reference intake of 23 micronutrients in more than 700 studies, and they found that pregnant and lactating women were only included in about 17% of those studies. And some of those studies most of them were only based on men. And as I was saying, this sort of arbitrary number that we have about carbohydrates is just pulled from calculations that were just done on wide population assumptions. So that in and of itself makes it very tricky. We estimate that in a pregnancy, you may need about 300 extra kilocalories per day, in addition to like a normal outside of pregnancy intake for a woman of that age. And that's usually equivalent to one extra small snack. So it's actually not the same as eating for 2 people, which is what a lot of people think pregnancy is a license for, is you can eat as much as you like or anything you like. So it is really interesting to know that much of the scientific evidence that the dietary guidelines are based around for pregnancy don't have a lot of rigorous evidence there, unfortunately.
So, since that's not there, it is individualized and under guidance. What should be the priorities when a person would want to follow a low carb diet and if they are diagnosed with gestational diabetes?
Yeah, so in addition to tailoring it to how they came into pregnancy, so just to recap that if the woman had normal metabolic health, then they are very likely to be able to tolerate a slightly higher amount of carbohydrates. Still wouldn't need to be as high as 175 grams. It could be somewhere between 100 to 150, but potentially less. And then if there is a metabolic condition prior to the pregnancy, or there was a therapeutic need, for instance, they had epilepsy, or there was another reason to maintain a very low carb approach, then we can still maintain that. And then 2 aspects again, where we just don't have a lot of strong evidence to make the claims that have been made, is that there isn't much scientific evidence to limit your fat intake in pregnancy. So there's a lot of worldwide dietary guidelines that have unfortunately demonized saturated fat, and the evidence for the pregnancy guidelines arise from rat studies that enriched the rat chow with refined soybean oil. And then they went on to measure pregnancy outcomes. And then the conclusions they came to were that the high fat diets, which were soybean oil enriched, had poorer pregnancy outcomes. But what we know about soybean is it's a seed oil, and that's quite high in linoleic acid, and that's a form of omega-6 fats that has been demonstrated in abnormal ratios to cause excessive weight gain and high blood sugar levels, which is not what you want in gestational diabetes, and elevated markers of inflammation. So we can then advise women, okay, we can have saturated, healthy, naturally occurring fats such as butter, ghee, coconut oil, and all dairy fats and the fats from meat as well that are occurring in their natural environment and natural matrix. And in fact, the Journal of the American College of Cardiology came out in 2020 to support across the board that the naturally occurring dairy fats and meat fats are not the main culprit, and nor do they cause long-term consequence for cardiovascular disease. And then the other aspect is that third macronutrient of protein, which we really try to heavily emphasize in a pregnancy, because even in places like America, when I think there was a recent study, it was published in 2021, about even on average, women are still under-eating protein through pregnancy. And they found that 40% of the women were under-eating the protein in the second trimester, and 67% of the third trimester mothers actually fell below their optimal intake, which should average about 82 grams of protein per day. And so increasing the protein intake is part of the work that we would put into place, and education we'd put into place about where to get that protein, because having higher protein reduces your blood sugar variability. And that supports all of those vascular changes that are occurring in pregnancy as well. So that's part of what the framework would look like, is much higher protein, higher healthy saturated fats, and monounsaturated fats, as well as a lower carbohydrate approach to the personalized to the level of insulin sensitivity that the person has.
So asking on, since we're talking about low carb, what about intermittent fasting?
Yes, so intermittent fasting can be undertaken in the preconception phase if there is some metabolic issue that's needing to be overcome. But it's actually not something that we recommend, and it's certainly not what I would recommend in my practice when you're getting very close to the time of conception. So what I mean by that is that sometimes it can actually take quite some time to sustainably achieve resolution in metabolic syndrome. And so if your plan is to fall pregnant within the next few years, it's actually a great time to start now, and implementing fasting could be one of those tools to help, to assist. But if your plan is actually you want to fall pregnant within 3 months or within the next 6 months, this is probably not the best time to be signaling unintentional calorie restriction, because what happens, and I've observed this occur with people, is that they may find that they will slightly start to undereat overall in case their fast, say, exceeds 16 hours. It might end up at 20 hours and then they've really only had 2 smaller meals in a day. So it's not signaling what we need to do pre-pregnancy, which is that you've got an abundance of nutrients and that you have an abundance of energy to sustain a pregnancy if it were to occur. So once a woman is pregnant, again, we advise not to do any forced or deliberate fasting. However, if they don't feel hungry and they would like to wait a little longer until the hunger sets in, then that is perfectly fine. We also know that it's not necessary to sort of force feed because of time frames, because in pregnancy, there are often times where food aversions will occur and there may be nausea associated, particularly in the first trimester. And unfortunately, some women get left with this for all of their pregnancy in the worst case scenario. So what we do is try and take advantage of the moments where there is an appetite and ensure that they have access at those times to the highest nutrient dense foods that they can possibly resource. And that way we can still combat that lack of overall energy, because one of the concerns is if you're nauseous and maybe vomiting, you're losing a lot of ability to take in nutrients. So I think we need to just always be really cautious about trying to get the most nutrient dense foods. So when you have a moment to eat and the nausea settles, you're not really having empty grains, which don't have a lot of nutrients, but you might be trying to favor nuts and seeds and dairy products that could be tolerated, and vegetables, as well as meat, if that's part of the way you eat, and ensuring that they are quality whole foods, so that when you do have a moment during the day where you're not feeling unwell, you're still getting the nutrients that you need.
That's very insightful on intermittent fasting, because following a low carb diet, our satiety naturally goes up. And if we have been following it for a while, we don't tend to eat frequently at all. So
That's correct.
So I'll ask a bunch of other questions. Are there any risks or concerns associated if somebody were to follow the low carb diet during pregnancy?
Yes, so one of the concerns that's been written into the guidelines here in Australia, and it may be similar in India as well, is that this was actually put into the Australian Diabetes Position Statement as of 2018, is that, and I quote, low carb eating should not be recommended for pregnant women due to potential folate deficiency, which resulting in an increased risk of birth defects. And that's the direct quote from that position statement. So that's the concern that has been raised locally about using a low carbohydrate dietary pattern. Now, I went and I took the liberty of looking at what study they referenced for this. And they actually analyzed data from the National Birth Defects Prevention Study in America. And it was from 1,700 American mothers of infants where they had stillbirths and terminations with neural tube defects. And then they also looked at 9,000 mothers of the live-born infants who were born without a birth defect. So these were the controls. And they were conceived between 1998 and 2011. And what they concluded was that the women in this study with the restricted carbohydrate intake, and this, mind you, was self-reported carbohydrate intake, were slightly more likely to have an infant with a neural tube defect. So there were a number of problems with this study, unfortunately, and so it was quite sad to see that it made its way into a position statement with such authority, because if this study was picked apart, it was actually comparing self-reported food intake, and it was asking the mothers about their intake up to 24 months after delivering their baby. So it was asking them to recall what they ate up to 24 months ago, about what was eaten even before they conceived, and then what was eaten through the pregnancy. So